Thank you. I'd just like to start off by thanking Parkinson Canada, especially Grace Ferrari, for inviting me to come speak with you all today. It's indeed a pleasure to be here in Toronto. For those of you who haven't seen it yet, this week we came out with a new guide, the printed guide of Parkinson's disease and driving. And for those of you listening today at home, it is available online for you to print, but you can also get them through the Parkinson Canada office in Toronto. So first of all, I'd just like to start off by asking everyone here in the room, just lift up your hand if you drive. Okay, so pretty much all the hands are going up. Keep your hands up if you have a movement disorder. Very good, so a lot of the hands are still up. Excellent. So this just goes to show how important driving is. And I feel that driving is kind of not discussed as much as it should be. I think some physicians still feel it's a little bit taboo. They shy away from talking about driving. They might feel that it'll affect the client-doctor relationship, but I think it's very important to talk about driving. And when I arrived here today, I actually met Sandy Ford, who I don't see right now in the room, and she, first of all, said, "I'm very happy to meet you, and I'd just like to tell you that you're very brave. Brave to be talking about this subject for the people in this room and for people across Canada." And she said something very interesting. She says it's very important to look at it as prehabilitation instead of rehabilitation. So starting to think about things and talking about things early on before you arrive to the day where you actually have to stop. Okay, so just my objectives. We're gonna start off just by talking about the natural aging process and how that can influence driving, how the symptoms of Parkinson's disease can impact driving, and how the team determines when someone should have a driving test. I'm sure you're all sitting there thinking, well, how does my doctor know that I'm not fit to drive? The role of the caregiver, because the caregiver has a very important role in the driving cessation process, driving cessation itself, and then we're going to finish off with a few recommendations. So what does driving mean to you? These are a few words that some of my clients have stated. It means freedom, it means competence, it means control, it means that I have my independence. And one gentleman actually said, driving is my life. He said, you can take my wife, but don't take my license. I can get a new wife. So, he left the office without a black eye because his wife was sitting right beside him, but I don't know what happened when they got home. So driving is very complex, okay? It's the most complex task that we all do on a daily basis. It's not neurosurgery, but it is a very complex task involving both physical and cognitive skills. And it's very important to know that it is a person's performance and not age that determines if someone is fit to drive. We have many people in the province of Quebec that are in their 90s and they still have driving permits and they're still driving every day. So it's not about age. So the aging driver. So if you live long enough, eventually, of course, you will have to stop driving. And the American Geriatric Society has some statistics on this, that men typically lose their license around 7 years prior to death, and women have a tendency to lose their license approximately 10 years prior to death. There's a little bit of difference between the two sexes, however, because women have a tendency to stop driving more freely, and men have a tendency to really hold on to that license and fight tooth and nail till the end. So the women are a little bit more freer to stop, and they realize that perhaps they're no longer fit. With the general population, however, the main cause of driving cessation is usually due to visual field changes when you are 75 years and older. So today, because I'm from the province of Quebec, I'm going to be giving you a little bit of statistics more related to the province of Quebec, but I think that there's tendencies that pretty much run the same across our country. So in Quebec, there will be an important increase in the number of 65-year-old drivers and up in the coming years. So these are statistics from the SAC, which is an acronym for the Société d'assurance automobile du Québec, and that is our licensing bureau in the province of Quebec. So in 2011, 16% of drivers were over the age of 65. In 2025, which is not too far away, a quarter of the drivers will be over 65. And in North America, Quebec is second to Florida for the percentage of drivers over 65 in terms of per capita. So the aging driver. So we all know that the most at-risk group of drivers are the young ones, the age 16 to 25-year-olds. They get into the most accidents, and it's usually due to speed, or it can be due to alcohol. The next group that is at most risk are the over 65-year-olds. Now, studies have been conducted, and 95% of accidents in the age group 65 and over actually happen to those who drive less than 3,000 kilometers per year. Now, I can't tell you how often I hear people come into my office and they say, well, Dad only drives to the pharmacy. Dad only drives to the grocery store. And these are the people that actually have the most number of accidents. And 45% of accidents actually happen, in most cases, less than 5 kilometers from home. Now, those that drive over 30,000 kilometers per year have less accidents. Now, don't get the wrong message here. I'm not saying that you need to drive more, that you need to practice more, and then you're going to be a better driver. These statistics can be explained the following way. Those people that drive over 30,000 kilometers per year are mostly doing highway driving. So they're driving 2 hours to go see their grandchild past Niagara Falls on a regular basis, or going to the cottage every weekend. So they're on the highways most frequently, they have cruise control set on, and there are not a lot of points of conflict to cause accidents. Those that drive less frequently, so that's less than 3,000 kilometers per year, are doing little local city driving in your rural town. So you have stop signs, you have stoplights, you have different changes in speed limits. You're going from 50 to 30. You have pedestrians, you have parks, you have kids running out in the street to get a ball. So there are more ways and more instances where you could get into an accident. So like I mentioned, age is not a criteria whatsoever in revoking a license. And the over 65-year-old category is at an increased risk for the following reasons. A medical condition. So yes, many people in this room have a movement disorder, but you could also have cataracts, you could have glaucoma, you could have diabetes. You have diabetes, you could also have neuropathy in your feet and have problems with sensory loss in your feet, and therefore knowing where your foot is, whether you're on the pedal or the brake, that could be compromised. You could have a mild cognitive impairment, or some people have a dementia. You could have a functional limitation. So, for example, someone's in a car accident and is now paraplegic. They have no longer use of their legs. So then, to keep people driving, we would do car adaptations. So instead of using your feet to operate the motor vehicle, we would use hand controls. Okay? And lastly, and more importantly, a visual problem. So vision, obviously, is crucial to safe driving. And visual changes with age include changes in your acuity, your peripheral vision, changes in depth perception, difficulty adapting to changes in light. And of course, as we get older, unfortunately, we can also get glaucoma or cataracts or macular degeneration. Or if you have diabetes, you would also be at increased risk of getting a diabetic retinopathy. So Dr. Postuma touched on this morning in his talk. He talked about contrast sensitivity changes, the difference between distinguishing different shades of gray, difficulty seeing at night. So visual acuity can be completely normal, but you could have difficulty distinguishing between different shades of color. So at the age of 80, you have 50% the contrast sensitivity that you had at age 20. So here's just a little example. It's not the best picture, but if you can see where the blue arrow is, there's a little kid standing here beside this car. in the shadow. So on the left, you might have someone who's perhaps 75 years old, and they're driving, and this is what they see. And the little child in the shadow of that car is not very well visible. As on the right side, we have someone who perhaps is 85 years old, so again, less contrast sensitivity, and the child is even harder to discern. So that's vision and natural aging. Now we're going to throw Parkinson's into the mix. So many people, when they give talks, they talk about Parkinson's as being an iceberg. What we see is above the surface, but what is going on is actually huge and much more extensive than what we can really see. So what we see is the tip of the iceberg. We see the motor symptoms, and Dr. Zanang and Postuma talked about this earlier this morning. The trap signs, so the tremor, the rigidity, the bradykinesia, the postural changes, the changes in balance, and falls. But what also plays a role is the non-motor symptoms. And Dr. Postuma talked about these as well, the autonomic disturbances, like the incontinence, the hyper sweating, there's depression, anxiety, apathy, cognitive changes, and another big one is the sleep disturbances. So Parkinson's disease and driving. Parkinson's is complex because we have physical symptoms and we can have cognitive decline over time. And the medications can have side effects. They can create dizziness, you can have sleepiness, hallucinations, periods of confusion, and these all together can impact one's ability to drive safely. And I have a picture here of the brain with the light switch. So you have your on periods, you have your off periods, and your symptoms can fluctuate hour to hour or day to day. So what do we typically see when we get into a car with someone who has Parkinson's? We could see driving too slowly, or vice versa, it could be driving too quickly. We could see stopping in traffic for no apparent reason, ignoring traffic signs, difficulty executing turns and lane changes. So for example, if someone has bilateral, so rigidity on both sides of the body, turning the steering wheel, typically when we turn, we're supposed to turn into the first lane, but it might take you 2 lanes to make that turn. And if this is a problem, there are changes we can make to your steering wheel to change the resistance, or different knobs we can add on to make this easier for you. We see drifting into other lanes. We see forgetting to signal, not checking the blind spots is a big one, stopping at green, advancing at red, and difficulty parking. So it is very, very well documented and studied that people with Parkinson's have visual spatial problems. Dr. Postuma mentioned earlier today about having his patients copy 2 pentagons interlocking, or your doctor may ask you, draw me the cube, something like this, and they're trying to assess your visual spatial skills. So these are 2 pictures that I took actually in the mall behind my house. And I don't know if these people did have a movement disorder, but you can clearly see there's a problem here. Parking on the line instead of between the lines, and in the photo on the right, you see that the car is not lined up appropriately. Not even close. So what do my clients say, people with Parkinson's? I typically hear, there's nothing wrong with my driving, there are worse people than me on the road, I've been driving for 50 years and I've never had an accident, I don't drive at night anymore, I've been driving longer than you have, I only drive close to home, to the pharmacy, to the bank, to the grocery store, etc. So the OT assessment. So my evaluation really starts in the waiting room. I walk into the waiting room and I call Mr. Smith, no answer. Mr. Smith, no answer. Mr. Smith is sitting in the corner, sound asleep. It's 9 o'clock in the morning, and on the 3rd time he bolts upright and he's ready to come with me. So this for me is a little bit of a red flag. If at 9 o'clock in the morning someone is so somnolent, falling asleep, they've come to their appointment alone and they're driving. So Dr. Postuma spoke this morning that Parkinson's patients can fall asleep within seconds. So this is starting to tell me a little bit of information about how this person is functioning. When we're in my office, we then start to conduct a little interview. We want to get to know each other. Of course, because I'm an occupational therapist, I want to know, where they live and if they have stairs and if they have a bathtub or a shower, all those things in terms of how they're functioning and what their environment is. But I also want to know, do they drive? And when they don't drive, well then, it's a sigh of relief. We don't have to, approach that very difficult topic. I want to know if they're still working, or even if they're retired, what type of work they did and their education. Because this tells me something. If they're still working and they're a lawyer and they have a very high level of education, but they're having difficulty with very simple tasks, then this is giving me information on whether or not they will be safe to drive. I want to know about their leisure. A red flag is the client is constantly turning their head to their spouse, even for simple questions. So how many stairs do you have to get into your house? They turn for their spouse to answer. What do you like to do for fun? They turn to their spouse for the answer. So if someone's having trouble responding to very simple questions, it's a red flag for me that something cognitively may be going on. If they've stopped an important activity, like they used to play piano all the time, or they used to read 2 books per week, or they're used to be on the computer all the time and they're no longer on the computer, we want to know, well, why? Is it because they just lost interest, or is it becoming more difficult? And when you kind of keep asking questions, they say, well, I have to read the same paragraph over 3 times, and then I forget what I'm reading. So this is telling me a little bit of information about how they are cognitively. Then oftentimes the spouse kind of peeps up and says, well, he's having trouble with the computer, even when I have the password there, he's having trouble copying it, or he's having trouble using the remote controls. So all this information is helping us in getting a better portrait of how you're functioning at home. Also, we want to know if there's any changes in driving patterns. So have you stopped driving at night, or have you stopped driving on the highway, or have you started to ask your spouse to drive more frequently? Then I look at activities of daily living. And Karen spoke about this a little bit, but just briefly. So I want to know how they're managing with their dressing, with their bathing, with their feeding. And oftentimes I hand my clients a shirt and say, show me how to put this t-shirt on. And if they're having trouble, for example, recognizing what the front is, what the back is, or they're putting it on backwards, or they're trying to put both hands into the same hole, this is what we call addressing apraxia, and this is a cognitive perceptual problem. So if someone is having trouble putting on a shirt, they really shouldn't be behind the wheel of an automobile. Has there been a history of falls? How is their personal hygiene? So sometimes we think, just because of a diagnosis, somebody might not be safe to drive if someone has a dementia. But someone could be living alone, and they come to their appointment, and they show up 15 minutes early, and they came by themselves. They found their room. They're dressed to the nines. Their hair is done. Their makeup's done. They look fantastic. So this is showing us, this person is doing really well despite the diagnosis. So this tells us a lot. On the other side of the coin, if someone shows up half an hour late and they haven't bathed for a week and their clothes are dirty, this is telling me, well, maybe he's not doing so well at home. And that's when we have the OT from the community go in just to make sure that he's doing okay, check to make sure there's no spoiled food in the fridge, etc. Other red flags are if someone's always missing appointments, or sometimes at the McGill Health Center, people go to the wrong hospital. Instead of coming to see me at the neuro, they show up at the general, even though they've been told to come to the neuro. So these are all things we take into consideration. So we do a physical assessment. So I want to look at somebody's range of motion, their trunk and their neck rotation, because of course you have to be able to turn, to look at your mirrors and check your blind spots when you're changing lanes. I want to look at your strength, your coordination. So your doctor has you doing all these things and seeing how fast your movements are. So I'll be doing the same thing. And I also may do, little tests with pegs to see how fast you are in your on state. I'm looking at tone, so essentially if you have rigidity, whether you have pain, looking at your endurance and talking about fatigue and sleep hygiene, because of course if you're not sleeping well and you're more somnolent during the day, it could put you more at risk behind the wheel. And of course we're looking at balance. The physical therapist I work with does the rapid pace walk, and this is a study from New Zealand. So the patient is asked to walk 10 feet, turn around, and come back to the starting point as fast as they can. And in this study, they found that those individuals that took more than 7.5 seconds to do the task were 2.5 times more likely than age-matched controls to be involved in an at-fault risk crash. And as your time increases, if it took you more than 9 seconds, you were 3 times more likely. So speed of walking transfers over to speed of being able to move from gas to brake, etc. So cognitive assessment, I do pencil and paper tests on a regular basis. You may be working with an occupational therapist who has you do tests on a computer, useful field of view, or some sort of test on a computer, but I do more pencil and paper tests. And we're looking to objectively assess your attention, your visual scanning, your memory, and what we call executive functions. Executive functions are very important. It's more the frontal part of the brain, skills like being able to multitask, being able to organize and plan, and this becomes impaired with Parkinson's disease. And I also sometimes, if I have an individual, for example, who speaks very little English, very little French, they have a grade 4 education, they moved here from Italy, from Greece, and the pencil and paper tests are not always very accurate. Whether they have a 14 on 30 doesn't really tell me anything because it could be based on their language or their education level. I do more functional tests with them. So I may ask them to do a cooking test with me. So in the kitchen to see if they're able to multitask, if they remember to shut off the stove. I may ask them to write a check if they know how to do that, and that's been an activity they've done in their lives. I do a wayfinding task. So my office is on the 2nd floor. I ask them to walk with me up to the 3rd floor, and then they have to bring me back. So they have to pay attention to cues, and I want to see if they're able to find their way. And then we also sometimes talk about medication and if they know what medications they're on and when they take them. So this is one test that we use a lot in my clinic, the MOCA, the Montrell Objective Cognitive Assessment. This is a French version, but there are 3 versions in English, 3 in French, and it also comes in other languages. And this, my friends, is the test that Donald Trump passed. Okay, he got 30 on 30, okay? So one of the members of the team, the nurse, the doctor, the OT may do this test with you. This is another test to look at visual perceptual skills, the motor-free visual perceptual test. They may ask you to do a maze test, and there are certain norms. So if it takes you more than 60 seconds to go through the maze, it's likely that you have the adequate capacity in the cognitive domains, visual constructual skills, executive functioning, etc., to drive safely. So this may be a test someone might perform on you one day. This is another test called the Trail Making A test. It's a test of attention and visual scanning. So this is, someone completed this test who was a 41-year-old engineer who didn't have Parkinson's, but had Huntington's chorea. And with Huntington's chorea, there's cognitive implications as well. So this woman took 82 seconds to complete this task. Now we have norms, so somebody who is her age and her education level, if they're performing at the 90th percentile, should do this test in 16 seconds. And someone in the 10th percentile should do this in 46 seconds. And she was doing it in 82 seconds, so it was quite slow. And this is one of the tests for executive functioning called the Trail Making B. It's the same person. It took her 6 minutes and 43 seconds. And ideally, an engineer, well-educated woman, she should have been doing it in about 40 seconds. And again, I said we have norms, because you probably wonder, well, how do they know that performing at this speed means such and such? So we have norms that researchers have done, so we know how you should be performing based on your age and your education level. So for the driving test, it's important to know that members of the team are legally allowed to report at-risk drivers. And all but 3 provinces in Canada, physicians are legally obligated. In Quebec, Saskatchewan, and Nova Scotia, they're not legally forced to. However, they did take an oath to do no harm, so they do have a professional obligation to report someone if they think they are at risk. And the gold standard is an on-road driving test. We can do pencil and paper tests and look at how you walk and how you move, but really the best way to tell is putting you behind the wheel and see what you do. Just so you know, if you apply for a handicap parking permit, a driving test may be requested, but mostly what they do is your provincial licensing bureau will send you some medical forms and they'll ask your doctor to fill them out, and then it's the doctors in the province that decide if you actually have to have a driving test. And driving tests can occur at your local licensing office, or if it's necessary, sometimes you will be actually doing the test with an occupational therapist at a rehab center or in a private clinic. So the physician, so this graph isn't super clear, sorry I didn't have a color version, but if we look, and this is in Quebec again, if we look in 2001, police officers and doctors were as likely to signal the licensing bureau equally. So in 2001, about 2,000 people were signaled to the SAC that something was wrong and they might need a driving test. But over the years, doctors have become more familiar with how to identify people who may be at risk. And you see that in 2016, that number has risen to over 20,000. So they've made 20,000 referrals to the SAC for people that have a diagnosis that might cause a driving issue with driving and that they should have a test. So am I safe? So questions you may ask, I have trouble finding and reading signs and having enough time to respond to them. I feel sleepy when I drive. The glare from headlights bother me at night. I have trouble looking over my shoulder to check my blind spot or to back up. I have had some near misses. Other drivers honk at me. I've lost my way while driving, or some people say I don't feel confident driving in new places. I get nervous and stressed. Sometimes I have trouble pushing the pedals. My family members are worried about me driving, or they don't want me to drive the grandchildren anymore. My medication makes me dizzy or sleepy, and some people say I have more trouble parking. So the role of the caregiver, I always say caregivers should drive with their loved one and look for warning signs, and we talk about that in the Parkinson Canada driving booklet. And sometimes I speak to the children of my clients and say, well, maybe just, if they're at your house babysitting, they go home, just maybe follow them home and see how they do. Are they staying within the lines? Are they driving the right speed? And it's important to communicate your concerns with the healthcare team. And usually in April, my phone starts to ring because a lot of my patients go to Florida for the winter. And the wives start calling me in March, April, when they're about to come back saying, I'm really worried about Mark, I'm really worried about Steve, I don't know if he should be driving. And they're afraid to tell me in the office face-to-face. So they're telling me, they've been in Florida and they have some concerns. Can I please address them the next time they're in the office? So it's important as a caregiver to report your concerns, and you don't always have to do it in front of the person if it's going to create conflict in your couple, but it's just important that you let us know what's going on and what your concerns are. And it's important to not delay the talk about driving until someone's driving has come to the point where it's gotten dangerous. And it's important also to know that a caregiver may be wrong about a loved one's driving ability. You may say, oh, he's dangerous, he shouldn't be driving, and they're fine, okay? So that's up to us to decide, and that's why the on-road test can be very helpful. You go for an on-road test and you pass with flying colors, and then everyone sleeps better at night. So this is a pamphlet I wrote, and again, like Dr. Anang and Dr. Postuma, I got a subsidy from the McGill University Health Center and the Patient Education Grant. So this is a pamphlet we're now giving to our patients in French and English, just to talk about start the conversation about driving cessation. Now, it's important to investigate different driving options with your team. So there's public transit, there's taxis, there's adapted transportation if you're having physical problems and you have difficulty walking a certain distance, you have a technical aid like a cane, a walker, you can usually qualify for adapted transportation. And it's usually the same cost as a bus ticket. So a taxi or a van comes to pick you up to take you to the mall or take you to the hospital for your appointments. There are also volunteer organizations, friends, family, church resources. So it's a good idea to start looking into this early on. And I also like to discuss the financial benefits because a lot of people don't think how much it costs to operate a car for a year. So when you look at car payments, license, insurance, repairs, winter tires, summer tires, gas, parking. I know when my patients come to the hospital, it's $25 to park their car. So you're looking at close, $10,000 to $13,000 per year, and that can pay for a lot of taxis. Now, pharmacies are delivering meds to your home, and you can order groceries online. So these are also different ways that we can adapt to changes in our driving conditions. So it's important to realize that driving is a privilege. It's not a right. It is definitely a privilege. And the driving conversation should start early on. And driving needs to be assessed as a team. Okay, so I'm not the only one who decides, it's not the doctor. Together, the doctor, the nurse, the OT, we're all talking together, and of course with the patient and the family. Your healthcare team is legally allowed to conduct your provincial licensing board. You can't say, I'm going to sue you if you call them, because you can't. The family needs to be involved. That's in bold. It is very important. The spouse, the kids, sometimes the parents, if it's a young onset person with Parkinson's. And it's important to not take the I'll cross that bridge when I get to it attitude. So some recommendations. See a vision specialist, because as you get older, your eyes are changing. You may need treatment for some visual changes. You might need changes for your glasses, different prescription. Speak openly to your healthcare team about driving. Don't text while driving. I know a lot of you are very tech savvy now. So when we're distracted, of course, we're at an increased risk of having an accident. So if you smoke and drive, you have a 2 times greater risk of having an accident. If you drink and drive, your risk increases 4-fold of having an accident. And if you text, your risk increases 25 times of having an accident. Okay, so these are what the studies show. So very important to not text while driving. Daily exercise. Very, very important. You've heard it all day long. So whether it's going for walks, going on your bike, doing Zumba, doing Tai Chi, doing a boxing class, exercise is very important on a daily basis. When we do more exercise, we have better posture, we have better range of motion, we have better strength, and we have better reaction time. Don't forget the cognitive exercise as well. I'm always promoting that. So when we retire, we don't have as many cognitive demands on the brain as when we were working full-time, 5 days a week. So it's important to keep the brain stimulated, whether it's reading a newspaper article, playing bridge, doing Sudoku, doing crossword puzzles. It's really important to prevent those cobwebs from setting in over time, okay, and keeping the brain stimulated. Treat your fatigue. Talk to your doctor about fatigue if you're not sleeping well. We heard a lot about that this morning. Try to implement good sleep hygiene techniques. If you're tired, don't drive, okay? If you haven't slept well the night before, don't drive. And caregivers should drive with their loved one and look for warning signs. So I said only drive when you feel at your best and when you're in your on stage. If your spouse drives, let them drive for you. Ideally, you should disclose your diagnosis to your provincial licensing bureau, and this is clearly indicated on your licenses no matter which province or territory you live in. Usually you're supposed to declare any change in your health status within 30 days. So you get a diagnosis of diabetes, you're supposed to let them know. You now have to wear glasses, you're supposed to let them know. You have Parkinson's, ideally you should let them know. Driving should be assessed as a team, the family needs to be involved, and again, the gold standard is an on-road test. So I'm going to stop there. I have my email at McGill here, and this is a picture of my team in our movement disorder clinic. We have neurologists who are all movement disorder specialists. There's a neurosurgeon. We have a neuropsychologist, 2 nurses, OT, PT, speech, and social work. And I'd like to thank them. They're a great team to work with. And if anyone at home has questions, they can feel free to email me on my work email. And I can also take some questions from you today. Thanks.
Thank you, Beth. I believe we have a few questions. Let me start over here.
Hi, I just wanted to ask you for the cognitive stimulation. I notice people are doing more and more on their phones and stuff like that. Mm-hmm. Is it as beneficial as if you do it pen to paper or reading a book physically and stuff? Do you have any studies on that?
For sure. Anything you do, of course, is going to help. Nothing's going to hurt you. Now, there's so many free apps on your phones. So a lot of people do Lumosity, or there's a site called neuronation.com that's very good. And I always say try to, when you go on these websites, you can choose what you want to work on. So I always say to work on the executive functions, the memory, and the attention. You can also go on Google and say games for attention, games for memory, and a lot of things will pop up that are free. And if a lot of people don't have computer, they don't have smartphones, so, going to the dollar store and buying a book of wonder words or crosswords or Sudokus is great as well.
Thank you for that presentation. You gave us a tremendously comprehensive look at the cognitive testing and all the things that might worry us about our family driving. You gave us so much, though, I just wonder, where is the tipping point? And when do you take that very difficult step of calling in help?
Well, that's the million-dollar question, isn't it? That's why it has to be really done as a team, and we're looking at a lot of factors, and it's not made based on one visit. We're following you. The neurologist may be seeing you every 3 months. I'll be seeing people every 6 months. So it's based on a number of factors, both physical and cognitive changes, and also what the family is telling us. If there's been a big change over the last 6 months and all of a sudden there's hallucinations playing into things and they're driving and a fire hydrant looks like a dog and things like that, well, that's, red flag. Oh, okay, I think it's time. So it's really on an individual basis. But like I said, when we feel that we're not 100% sure, sending someone for a driving test really gives us the answer we need.
Thank you. A very good presentation.
Thank you.
When do you start addressing the subject of hands-free driving?
Hands-free driving?
Yeah.
For no texting?
No.
Automatic.
Oh, automated cars. Well, that's going to be the topic of the future. I can't really comment too much about that today, but that's, yes, that's going to be in the next year or so, something that's going to be coming into to play for sure.
Just another question regarding driving. As you age, no matter what's wrong with you or right with you, you have trouble. You lose mobility. You have trouble looking over your shoulders. Now a lot of the vehicles, newer ones, come with the blind spot things. And even my grandson, when he was 16, they didn't even tell him to look over his shoulder at his driver's license. Maybe that was a poor driver that was teaching him. But they told him to look in his side mirrors. So does that ever come up? Have you ever heard that before? Don't turn like I do, all over the place to see. But you can just use the side mirrors.
Yeah.
I don't like it.
Yeah, and if people are having, problems with a lot of rigidity in the neck and the shoulders and they can't turn, seeing an occupational therapist can provide, we can put different kinds of mirrors so that you get a better view without having to turn that way. So that's how the occupational therapist can be important in that regard. Yeah.
Okay.
Yes. So technology's come a long way to help us. Exactly. Yeah.
Okay. I just want to say, on behalf of Parkinson Canada, I want to thank everyone, especially our speakers, for taking the time to come out here today and to share such valuable information. Give them a hand, please.